candidacy criteria, they have been expanded. Children with inner ear malformation, with and really beautifully explained. We can do also additional disabilities like autism or any other additional we can do it. But you must understand how CA functions. Okay. So what is this is not an auditory stimulation. We don't have that normal chemical neurotransmission here. What we have is an electrical stimulation. Basically, we are delivering electric shock to the neurons, ganglion neurons, in very, very micro quantities. Okay? It is not natural to think, and whatever response depends on patient's peripheral neural population, how much ganglion neurons and he has. And also, this neuroplasticity in children is so good, and in young children, you can easily stimulate these children even if they have less number of neuroganglion neuron cells, and that even limited number of nerve fibers that provide results to this children. What is the least number required? They say even 3,000 is enough. Of the 48,000, there 48,000 population. Even if 3,000 survives or 3,300 survives, still we can give useful stimulation to the children. Okay, and it provides potential benefit. And I told you that 3,000 per annum does not necessary. Earlier till now, absent cochlear nerve means absolute contraindication for cochlear implantation. But the recent advance in MRI, what they showed is individual evaluation of the 4 nerves within the intra-aortic canal can be done. That's important. Assessment of presence and assessment of size of the cochlear vestibular nerve, individually cochlear nerve, vestibular nerve, and earlier the narrow limit for normal size intra-aortic canal means the suspected absence cochlear nerve, and then CT scan. If it shows 4 mm is normal, if less than 4 mm, and if that is less than 1.5 mm of normal. And one more thing you need to understand is, even if there is a normal appearing cochlear and intra-aortic canal, that is 4 mm canal, still that do not have the presence of cochlear. So this is the ambiguity sometimes we face. Because as far as cochlear nerve hypoplasia absence it can be congenital. Now we have noticed that it can be developmental also. Okay? Yeah. So there are different types of cochlear nerve dysplasia. Now all these cochlear nerve abnormalities have been put under now one name, that is cochlear nerve dysplasia. There are 3 types have been mainly studied. That is one is aplasia. That's what cochlear could not be identified in either axial, coronal or oblique plane of sagittal images. Okay? MRI not identified. Hypoplasia means when it appears decrease in size compared to the other nerves. Okay, decrease in size, but it's there. Imperceptible cochlear nerve means extremely small nerve that would appear absent owing to the limited spatial resolution of MRI. MRI is not good enough, even 3 years Tesla MRI is not good enough to identify the cochlear nerve. So imperceptibility. Okay. Yeah, in the CT scan I told you, now the standard has been accepted is if it is less than 2 to 2.5 mm, that's a absolute contraindication. As you can see here we have a 4 mm intra-aortic meatus, where here you can see it is less than 4 mm. In this case actually only facial nerve was there was no cochlear nerve at all. Okay, you can see very narrow intra-aortic meatus CT. But we have now such a very good MRI where they can do a 3D reconstruction, that is maximum intensity projection. You can see beautiful 3D reconstruction of the complete labyrinth and cochlea, and also individual nerve can be identified. This is a inferior view of the cochlea and the intra-aortic meatus, where you can see anterior inferiorly we find the cochlear nerve, and posterior inferior vestibular nerve. Superior view you can see anterior superior facial nerve, and we have anterior inferior superior vestibular nerve. Yeah, the other sequence they use is constructive steady state sequence. Again, they also show distinctively the nerve fibers they differentiate. Okay, through that also we can identify, in the here inferiorly you can see easily the cochlear nerve and inferior vestibular nerve. Superior view you can see the facial view anterior superior, and post here the superior vestibular nerve dividing into macula and other you can see. So this is last. So when we want to assess, we have to specifically ask the radiologist what do you want. You want a sagittal oblique view of the cochlear nerve. It cuts through this like this, and that will give you a picture like this. You must study the cochlear nerve from CP angle towards the intra-aortic angle, and also you should know what is the arrangement in this. Okay, different things. What is the arrangement at the front stem level? You should be able to identify. As you can see here, front stem level superiorly we have the facial nerve. Inferiorly, entire cochlear vestibular nerve with single complex. You can see there. This is how it's seen. As we come out in the CP angle, what happens is the cochlear nerve and vestibular nerve, they get separated. There are spatial of continuousness. As we come to the porus of the external canal, that's lateral, the medial end of the external canal, as you can see here, the facial nerve stays there, cochlear nerve comes to anterior inferior position, and vestibular cochlear nerve, this nerve will start getting divided. So this picture starts. Okay, but once we come to the fundus of the external canal, this is how it is situated. Here we can see anterior superiorly the facial nerve. Okay, then inferiorly we have our cochlear. You can see the thickness is little more thicker than the facial nerve. Posteriorly here what we have, posterior superiorly we have the superior vestibular nerve, posteriorly the inferior. Sometimes the singular nerve can be seen. So this orientation we should have identify. So commonly studied by this study even the CP angle also. So I told you the CAC sequence you will be able to see both anterior superiorly the facial nerve and the posteriorly you see this is coronal view. Yeah, here we see vestibular nerve, superior vestibular nerve, and this is inferior vestibular nerve. Okay, this is posterior view. Okay, the anterior view here, this is an axial view. Here what we see is again here this is the vestibular nerve, this is from inferior part. Okay, vestibular nerve. Okay, yeah, here this you should be able to study the sagittal optic view. This picture is very important. The anterior superiorly we have the facial nerve, anterior inferiorly we have the cochlear nerve, posteriorly superiorly we have superior vestibular nerve, and posterior. So all these three four nerves we should be able to identify, distinguish. That's important. Also there is a classification, and now we know that as much as 80% of children with severe hearing loss they have that is dysplasia of the cochlear nerve. Okay, that's quite big now. Once what happens is you do about 10 pieces of cochlear implantation, your hands start. So you are not getting a lot of this. And once you have already done about 10 pieces, you can't be successful. You want to start doing that. You want to start doing that. But one caution, one you need to understand. Again, there is a classification. This is Gold's classification. The type 1 is total absence of cochlear nerve, and there may be normal classification in this condition. Type 2, A and B is then type 2A is cochlear branch is absent or hypoplastic. Vestibular nerve is present here. The labyrinth may be dysplastic from minor dysplasia to common caries. Type 2B, cochlear branch absent, hypoplastic, vestibular nerve present, there may be normal. These are variations we can have it, and here I showed you the normal vestibular cochlear nerve, how it goes. Okay, so as we go here, you can see here, you see the anterior and the anterior superiorly, the facial nerve, here superior vestibular nerve, we don't see any nerve. So that means there is cochlear nerve hypoplasia, not seen at all. Yeah, you can see another case here. Anterior inferiorly, nothing is seen here. You can see the anterior inferiorly, there is nothing. So this is another cochlear nerve. The 4 eyes should be neat. Here in this condition, there is no cochlear nerve. You can see there is no connection between your cochlea and the intraocular. You can see total. We see the vestibular nerve, vestibular cochlear, the vestibular nerve is a single complex. We also see facial nerve, but there is no cochlear. Here again cochlear nerve absent, cochlear nerve absent. Yeah, this is IP1, that is the common cavity. Here there is no cochlear nerve, seen at all. There is no cochlear nerve seen in this case also. IP2 is there. Okay, that is modeling. Again there is no connection, no cochlear nerve. So this is what we have to remember. So what is now? Whether it is cochlear implant or the auditory branch implant, that's the question. See, one thing you should remember is the studies also, multiple studies. There are some cochlear fibers problem with the vestibular or facial nerve, not as a separate nerve. You may not see that on MRI, but still there may be some cochlear nerve there. And existence of anastomotic connection between cochlear and vestibular nerve bundles having root and seed. They are before doing ABI, they try to stimulate the cochlear nerve directly, whatever the complex is there, vestibular complex, and see any auditory stimulation. They try to do a intraoperative before they do auditory branch implants. And they found this, okay? But also limited spatial resolution of MRI MRI, a small number of cochlear fibers are present, but they are not identified by current imaging. They found that some fibers, but MRI did not detect at all. Okay, so this is not identifiable. They call imperceptible number. So for radiological markers, what we have been using is again the electron canal diameter, cadence of the bony cochlear nerve canal I showed you, status of the cochlear alveolar strength and cochlear morphology, all those things we need to study. But one listening study we have been using, what has been advised is that is electrical ABR, that is electrical stimulation ABR. If there is a consistent presence of V wave, and they say you go ahead and do it in class. But that is also not very true. Again, there is a controversy. There is a lot of studies, and Song et al. The thin cochlear now they done promote electroconvulsive stimulation test, and they found that is not any auditory response. There was no V wave at all. Whereas Warren et al. And other things they found that EABR and critical for entertaining candidacy for fundamental and here another, and this Song et al. They conclude saying it is not the EABR. Preoperative auditory response due to auditory and behavioral auditory response is very important. Okay, and behavioral response taken auditory response. They are more accurate of the EABR. That's what they propose. And of fact, you have to remember cochlear implantation. Also, even if there is a cochlear nerve, there may be disordered there are less number of nerve fibers may be identified as EABR, but disordered temporal processing may be there. And inadequate perfect protection of vestibular fibers, fiber quality may not be good. And also depends on number of spiral ganglion cell population. That also is very important. I totally agree with the and also signal auditory pathways. We have to do other auditory that advanced the next set of the studies like LMR and other studies you may have. Also time of auditory stimulation. If we do it implant earlier and do stimulation, they may be a good response. But as a child grows, like beyond 4 years or something, because there is no stimulation at all, these nerve fibers they are not working. So you have to do early, for all you want to be intervened. And now what now? If the patient, you have found that there is a deficiency, what to do? See, some children with that are below the system current and so in these children you find that there is some fibers you have identified and whatever is possible. So cochlear implantation is still a viable option. But only thing is careful counseling of the family possible because child doesn't have any other option. Okay? You cannot outrightly say that I cannot do implantation. Okay? And that also the patient, if you have even little doubt that there are some fibers out there, I think you must take a chance before you implant. That's what most of the literature reviews they say.
But ethically and medically,
yeah.
if we talk about, isn't it a hidden trial for something such costly thing you're talking about? So there are some medical legal aspects also, and ethically also if you think about it. Like if you're going to have an implant which is
that is the critical question now. You see this there are just not this object that cochlear nerve deficiency. There are many issues around cochlear implantation where there is, we don't have clear cut definition, whether we can do it or not. See, these are some special situations, where like, it's a 50-50 chance, either you can help or you cannot help. You have to take a chance, but you do that explanation properly. Don't promise them, you promise less and take right now, actually what we should be having is even the EABR, also not what we should be having is, we should be having testing array with it. We should have what? Testing array. Testing electrode array. Yeah, this is not an implant itself. You put do a cochleostomy, you put a testing array, you do a stimulation, one day you will find out if any response is there. Then that should be, this is the only paper one I got somewhere to read.
With what you will stimulate?
Stimulate the cochlear.
With what? You can't just open a cochleostomy and put a premonitory stimulation test. is going to, even if a sterile electrode is there. See, what you are saying, we have also come across a very reputed surgeon from Delhi, and I got a family where the child had bilateral cochlear hypoplasia, the intrautic canal was narrow. The family spent 12 lakh rupees, they got the highest, the topmost model of nucleus. The family came for me for a second opinion. They said they had chosen the worst ear in that case and they had implanted the hearing aid on the better ear. Now they said out of two sides in the MRI, the intrautic canal, the cochlear aperture was better seen on the left side and was not that great seen out of the two, maybe a difference of 19-20. They said, sir, do you advise that we should get an implant done? They said, we are fine, we have spent 15 lakh rupees, but then if we get the implant done on the opposite side, it might give him a 20% more chance. So, because the surgeon counseled the parents so well, they were not in a kind of a maybe shock that why the child is not doing well. They already had every idea about it, what is cochlear hypoplasia, and we are seeing such a patient where I think the parent was more well read than I am right now. He had researched all the papers in US, he got those articles and everything, and he came to me with the articles. He said, these articles are saying that there is this chance, there is this chance. So it happens in Delhi, but then I would say that
no,
I don't know this paper you are mentioning.
Yeah, about Jaipur. I know a case who is
not
coming
anybody
up,
else.
who was operated by some other surgeon in Jaipur, and 10 lakhs was spent, and now he is roaming around with other surgeons.
So because the counseling was not happening done.
So even if you counsel the other guy, if he puts in something, there are some medical legal issues. He is gonna
see that is where the medical fraternity is lacking now. So the patient came to me and they told me, sir, we were told that we have a guided prognosis. I said that's so clear, so nothing can be done.
See what happened. Recent Portugal, I was in the ABA session. I went with specific intention of listening to this. See this, I think one of the colleagues who has done maximum number of ABA, his assistant was there. And in this panel discussion, this was the idea which was brought. That is, see now the EABR is not foolproof. Okay. Now we are not able to clear cut make out an MRI or CT scan that make out cochlear hypoplasia. They are not this thing, for sure not able to say it's deficiency also. Now what do we do? How do we go ahead? So this was one of the ideas which was put forth. That is, we should have a testing array. Wait till you do a cochleoscopy before cochlear implantation. Put a testing electrode and check. If there is some response, then you go ahead and put your regular cochlear electrode and close it.
Which article you are mentioning about, Prahlad?
Pardon?
Which article you are mentioning?
No, this is the recent Portugal.
The Polish guy who spoke about this.
No, this was in the panel discussion.
Okay.
Test array. Yeah, they spoke about test array that we don't have.
No, the company is providing that test array. No.
See, this ABA surgeons were proposing this.
Okay.
Yeah.
Isn't there some functional MRI sort of thing? As neurologists and neurosurgeons, they have got something like a specialist tract is impacted more than the other tracts, the neural tract. Something like that could be done with the nerves also.
Functional MRI is one possibility, but it's still not, not available at least in our country. I mean, I don't think anybody is in Delhi they are able to do functional.
But in epilepsy and all, they are doing something like that. A particular tract of the brain is being highlighted on MR. Maybe some neurotransmitters there.
See, if you search the literature, it will say that very few patients have got cochlear aplasia. They always have some fibers going. It is like how many fibers are going and how much response it will show.
Yes.
So that is the and like I always say, it is not the MRI. It is your audiologist who is going to give you a lead that this child is showing a good response on behavioral audiometry and on TD-ABR. So it's a combined decision.
We have had cases of thin nerve at Kaplan Center. We have seen that the nerve is not visible on the MRI, but the audiologist has told us that there are some responses.
This is what I am saying.
So the nerve fibers do pass through, and somehow, and the child also had a common cavity along with a very thin or almost absent nerve. So the child does now respond, and the child is able to identify a doorbell and even identify that the phone is ringing. But the speech is not coming up, but at least the child is aware that there is something around. So you should not do the case. You should do the implantation. But counselling is, as I said, counselling is very essential.
Second question is that normally when you do any ear surgery, moment after the surgery, mastoid surgery and all, you have labyrinthitis. In this case also, when you are fiddling around window, you have vertigo, everything affecting that.
I'll ask my audiologist, Vishal, to speak anything because we are not doing that routine this thing. Okay. And second question was?
You have labyrinthitis following any medial surgery. In this case, would you have that kind of toxic labyrinthitis, or stage 1 labyrinthitis and vertigo, following round window insertion, etc.?
Yeah, see, some of these patients can have those symptoms. And it's also a different, there are several papers explain vestibular effects or vestibular deficiencies or cochlear implantation. They do occur. There are a lot of symptoms are there that we are focusing on complications. Complications following
Most of these vestibular problems are because we don't achieve a scalar tympani insertions. Most of these are whether it is completely ossified, so you do a scalar vestibular insertions, or there is a study by J. Thomas Prahlad which says that he studied the trajectory of the electrodes into the cochlea, how it was done. He said about 22% of the electrodes pierced the membrane and crossed from the scalar tympani and went into the scalar vestibular. Nobody actually knows where actually the electrode lands up. Only with the peri-round window cochleostomy, where you have a straight trajectory, they have done this histology sections for these few temporal bones, in which 85 to 90% could maintain the scalar, 100% scalar tympani insertions. But few of them, they crossed and they pierced the membrane and they went into scalar vestibuli. If you majority access into scalar vestibuli, if you don't have an option, like I said, in cases where there is complete ossification or there is a bud-like cochlea, you don't have an option, you have an oval window, you have a stapes foot plate, you take off the stapes foot plate, but you concept the family that he is going to get vestibular stimulation. But vestibular adaptation does take place, and switching off few of the electrode does help in habilitation of these kids.